Audible?
Yes, doctor, you are.
All right, great. Very good evening to one and all. Welcome to everyone and to the faculty as well. It's great pleasure for me to introduce to you again another two eminent faculty, one from a global level and one from a national level. So for the global perspective, we'll be hearing from Dr. Jessica McFarlin. She's an associate professor of neurology and the division chief for pain and palliative and supportive care at the Kentucky Neuroscience Institute. She's got a dual fellowship in neurology and hospice and palliative care. She's done her residency from the Duke University and her MD from University of Kentucky. Her primary research focus is in communication training of physicians and in delivery of high quality palliative care in patients in the intensive care setting. She has about 14 publications in her name, and she's on various boards for certificates and special training in psychiatry and neurology and neurocritical care as well. So a very good morning to you, ma'am, from where you're joining us, or good afternoon, I suppose, and a warm welcome to you.
Thank you
Next,
so much.
we have Dr. Suneesh S., who is an assistant professor in internal medicine, working at the MOSC Medical College in Kerala. So his education ranges from Kerala to a national level and again at London as well. His presentations and activities, he is part of various academic forums, speaker at scientific forums, actively participating in various conferences. He keeps in par with recent advances and learnings in new horizons in oncology. He is a member of various associations like the Indian Medical Association, the All Kerala Medical and Pediatric Oncology Association, International Academy of Clinical Hematology, Royal College of London, etc. He's also involved in various research projects. A very warm welcome to you, sir.
Thank you.
So I'll leave it to both of you to decide who would like to go first.
I think that the agenda for the day has me going first. So if you don't mind, Dr. S., I can go on and get started.
Sure. Please go ahead, ma'am.
All right.
Dr. Suneesh, we'll come to you as soon as ma'am's presentation is done.
Okay, thank you.
Thank you, sir.
All right. Well, first of all, thank you all so much for letting me join you again. I got to join last year and really learned a lot. I'm Jessica McFarlin, and I'm going to talk to you all about the changing face of palliative care, specifically in oncology practice in the United States. I am a neurologist by training, but I'm actually the division chief of palliative and supportive care at the University of Kentucky, which sits in internal medicine. A little bit about Kentucky and where I'm speaking from right now. So Kentucky is sort of a South Midwestern state. We're famous for things like bourbon, horses, and music. We also have the longest cave system in the world in Kentucky. It's called Mammoth Cave. If any of you all ever make it this way, I would love to host you and show you around. My email's at the end of this talk. But one thing that I think is interesting about Kentucky that's different than some other states, especially the coastal states in the United States, is that we are primarily a really large rural population. Most of our patients do not have access to specialty care like palliative care, so that's growing. But I wanted to point that out because that's the lens through which I think about palliative care in the United States. What I hope to do today is really tell a story about the current face of palliative care in the US in oncology. I'll start by exploring some of the misconceptions that delay the practice of palliative care in the US. I think it's really similar in some ways to the delays in other countries. I'll describe some of the recent landmark trials in palliative care for patients with cancer and how that's affected oncology care in the US. And I don't have any disclosures. Please feel free to put things in the chat as we go along. I'm not able to see the chat while I'm giving my talk, but certainly at the end, I can answer any questions or we'll have a chance to talk as well. So some of the things that we know is that adults living with cancer have a lot of unmet palliative care needs. This was a study of about 200 patients, just a survey done about 10 years ago to sort of explore that. Patients noted, and these were patients already cared for by an oncologist, 62% noted that they have a lot of symptom-based needs or psychological or emotional needs that are just unmet by the type of cancer care they were getting. They also noted a lack of met needs in medical communication and information sharing, some spiritual and existential distress, and then social needs such as planning for the future, getting to and from clinic. So we know that there's a lot of unmet palliative care needs for patients with cancer. And we also know that these exist for children as well.
Dr. Jessica, can I intervene?
Yes, ma'am.
Have you shared your screen because we can't see anything?
Oh, well, I thought I had, but thank you.
I was just about to ask that. Thank you, Raju, for reminding.
Yeah. How's that?
Yes, ma'am.
Yes,
Presentation view would be, yes, perfect, ma'am. Good to go.
Excellent. All right, I'll just show you. There's my objective slide and domain and needs. And then, as I was mentioning, we know that children have unmet palliative care needs as well, and also caregivers express a lot of unmet palliative care needs in both adults and children. We know for children at the end of life, there's a great deal of suffering, things like pain, fatigue, and dyspnea. Now, ideally, in cancer clinics, these needs should be screened for. The National Comprehensive Cancer Network has guidelines that indicate that these needs should be assessed at every time that a patient is seen. And although that's done, sometimes oncology clinics do not have the resources that they need to meet practical problems such as childcare, transportation, family problems such as missing work or dealing with grief, things like symptoms such as out of control pain, nausea, and vomiting that might be keeping people from continuing treatment. And the higher distress scores are, we know that leads to increased hospitalization and a lot of increased visits to the emergency department. In our particular hospital, in our particular cancer center, when we looked at reasons that cancer patients were coming to the emergency department, the #1 reason was pain. So rather than waiting to see their oncologist to discuss it or maybe having some unmet needs, they were using the emergency department, which is really hard to get good care in the emergency department, not because we don't have good emergency room clinicians, it's just because they get triaged really low and it can take a long time to be seen and assessed. So despite this knowledge of what we know about patients with cancer, there are a lot of barriers to assessing palliative care. And some of these comes from misconceptions of healthcare providers. So misconception #1 is that people still think that palliative care is only for dying patients. And these are some quotes from a survey that was done by the Center for the Advancement of Palliative Care from doctors and nurses. So things like palliative care is comfort care during one's last few weeks or days of life, that the goal is to keep a patient comfortable and out of intensive medical treatment, that it's for families to give them comfort and options for what to do at the end of one's life, but really focused on those last days of weeks. We know that palliative care should be given throughout the course of a serious illness and at the same time as disease treatment. I really love this slide because it shows how ideally palliative care could be given from the time of diagnosis with an oncologic disease to the time of end of life. And at the end of life, we would transition more to hospice care, but that palliative care needs increase during the time, and palliative care access ideally could increase throughout the care of the illness. Misconception #2 that some oncologists have is that telling patients about palliative care will scare them or lead them to a fear of abandonment. This is from an essay from Dr. Diane Meyer, who's a leader in palliative care. And she says, "I don't want Jenny to think I'm abandoning her." She was writing about her patient. And we know that cancer doctors express care and commitment through tests and new treatment plans. We always want to give more, but that over treating patients near the end of life is a major driver of low value care. Patients don't know that physicians are not always trained to talk with them about prognosis goals and values. And also patients assume that we will tell them when time is running out and what to expect and how to navigate this part of life. But we don't always get that type of training. So it can lead to this sort of awkwardness that if we refer them to someone else at this time, maybe we're abandoning the patient. Sometimes providers think that maybe people are scared of palliative care, but the truth is most of our patients in the US do not know what palliative care is. It's increasing, but most patients don't really have a strong opinion about what palliative care is. They don't have necessarily associate it with abandonment or hospice care, though a lot of providers think so. And you have to excuse me, allergy season is really high here right now, so I've got a bit of a cough. So misconception number 3 is that my patients aren't ready for palliative care. And we know that if patients are not aware of their prognosis or aware that they might be closer to the end of life, they may choose to prolong treatments that may not be helpful or underuse services that support quality of life. So potential overuse may be things like life-sustaining therapies or increased chemotherapy in the last 14 days of life. Underuse might be missing out on family support or early conversations or spiritual and psychosocial support to help face the end of life. And the next misconception is that palliative care creates a self-fulfilling prophecy or takes away hope and increases depression. This is another quote that I really like from pediatric oncologists, that offering palliative care is a challenge for the team and family because it's perceived as giving up hope for recovery or cure. So really these ideas that keep people from referring them to palliative care specialists. Luckily, the past 10 years have seen a growth of evidence-based trials to attempt to overcome these misconceptions and create opportunities to integrate palliative care into oncology practice. So the research community really wanted to pay attention to those misconceptions and also do trials to show that those misconceptions were not true, that we didn't worsen depression, that we didn't create a self-fulfilling prophecy, that patients didn't necessarily not live as long. So by helping break down those misconceptions, the goal would be to increase access to care. So there are 3 really great studies that I want to talk about. One is by Dr. Jennifer Timmel, and it's the effect of early palliative care on quality of life, aggressive care at the end of life, and survival in stage 4 non-small cell lung cancer. The next is by Dr. Marie Batikas, which is early versus delayed initiation of concurrent palliative oncology care. And finally, with Dr. El Jawari, the effectiveness of integrative palliative oncology care for patients with acute myeloid leukemia. So doctors that have looked at both palliative care for solid tumor patients and patients with what we consider liquid tumor patients. So both groups of those patients were done in these studies, and I'm sure you all are familiar with these as well. So first, looking at the Timmel study, this was one of the earliest studies done in the outpatient setting. So Dr. Timmel looked at 150 patients, and then they closed it with metastatic non-small cell lung cancer, diagnosed really early, so within the past 8 weeks, so early palliative care. And these patients, in order to enroll, had to have a functional status of 0 to 2, so good enough to get treatment. And they were randomized to either early palliative care integrated automatically with standard cancer care, or standard cancer care at the time, which meant that patients only received palliative care when it was requested either by the patient, the family, or the oncologist themselves. So it wasn't automatically given. And this was presented at ASCO in 2010. So what they discovered was at 12 weeks is that patients that were in the early palliative care score had a better relief of their symptom burden compared with the standard of care scores. And so their lung cancer scores, their trial outcome index, those are all markers of functional status and relief of symptoms, were better in those groups. And you can see that there was a change in their FACT lung score and their FACT lung trial outcome index. So those are, again, functional status and quality of life. So those improved across the board, which is great. That's what we wanted to see, that palliative care was making an impact. We also saw that there was less aggressive end-of-life care, so decrease in the amount of chemotherapy sometimes given, and increase in patients without aggressive end-of-life care, and also an increase in documented resuscitation preferences. The standard in the United States for resuscitation is full code. So patients at the end of life, even if you call an ambulance to come home, the standard of care is to attempt resuscitation. So more people change their documented preference to not receive resuscitation. So this was great, but the trial also wanted to show that people weren't dying sooner. That was their, one of those myths. So what the study showed is that the median estimates of survival were actually better than patients with early palliative care. So sort of a surprise there, I think. So the average estimate of survival was about 10 months in the entire sample. And you can see that patients in the palliative care group lived about 11.6 months. And the standard of care group was 8.9 months. So that was a surprise, but also reassuring that we were not worsening outcomes. So the next trial, this was done at University of Alabama, another rural state. This was early versus delayed initiation of palliative care. And this looked at the effects of early versus delayed palliative care on quality of life, symptoms, 1-year survival, and use of resources. What they found was that early entrance participants, patient-reported outcomes were not statistically different, but their 1-year survival after enrollment was improved compared to those who enrolled later in palliative care. So that's a really important area for us to understand more in palliative care, is why in these studies are we actually increasing survival by a few months? Is that because of better symptom management, decreased hospitalizations, less use of aggressive care that maybe actually improves some length of time? It's unclear now. We're not quite sure what's in the syringe, as they say. But I think that's a really important area for studying. But again, reassuring, I think, to oncologists that we're not worsening care. And I love to look at this because it looks a little bit similar to the studies we're seeing come out with the autoimmune and checkpoint inhibitors, seeing that they're actually increasing survival in a similar way as palliative care is. So I thought that was kind of cool. And then finally, this was the study done in blood cancers. So this was effectiveness of integrated palliative and oncology care for patients with acute myeloid leukemia. They enrolled patients in the hospital setting that were there for induction chemotherapy in 4 academic centers. They randomized them to, very similar to the first study, automatic palliative care at the time of admission, or usual care, meaning they didn't get it unless it was requested by the family or the oncologist. And they looked at the quality of life and the functional assessment of cancer for leukemia patients. And what they showed, you can sort of see on the findings, is that compared to 2 weeks, because this was done really early at induction, patients in the intervention had better scores compared to patients that didn't. So improved functional assessment and improved quality of life. So these 3 studies have been practice changing in the United States. It helps us see that early palliative care leads to significant improvements in quality of life and mood. So dispelling some of those myths that people would feel abandoned or people would feel depressed, and led to longer survival and less aggressive care at the end of life. And this is important to oncologists, to patients. It's also important to health systems when we think about keeping people out of the hospital, providing the best type of care, and saving money to health systems, that this is important. So how has this changed our practice? First and foremost, it changed the American Society of Clinical Oncology practice guidelines. So they now state across the board that patients with advanced cancer should be referred to interdisciplinary palliative care teams that provide inpatient and outpatient care early in the course of disease, alongside active treatment of their cancer. And they go one step further and say that newly diagnosed patients with early palliative care involvement within 8 weeks of diagnosis is suggested. Now, that's extremely hard on our palliative care teams. And I'll talk a little bit about some of the barriers to this, but it is really great to see that that's in the guidelines now as a result of these good clinical trials. And the American Society of Clinical Oncology also uses these trials to better assess what palliative care can include when given alongside oncology care. So things that we already know about as people that are training for palliative care or have a background in that. So rapport and relationship building with patient and families, symptom distress and functional status management. So things like physical therapy and occupational therapy, suddenly we start to see more of that in palliative care clinics. Exploration of understanding and education about illness and prognosis, clarification of treatment goals, assessment and coping of needs, assistance with medical decision-making, coordination with other care providers, and provision of referrals to other care providers as indicated. Now, meeting all of these needs, as you can tell, takes a lot of time. And for oncologists, this can be overwhelming to try to integrate all of these things. So having specialty palliative care providers and clinics that they can refer to is really important. The same guidelines suggest a model that takes about an hour a month for each patient to just attend to palliative care needs. Well, that can be overwhelming. So one goal of outpatient clinics now is to try to partner with oncologists to try to save them some of the time and sort of think through who's going to treat what as we care for these patients. How can we best partner? So to help meet those needs, we have seen more US hospitals, especially larger hospitals, growing their number of palliative care programs in the US. You can see the percentage of growth between 2000 and 2020. So really larger hospitals are increasing that to try to meet that need, which is exciting. It's really great job security for me and other people that practice palliative care. And there's increasing number of cancer centers that try to ensure they have access to palliative care consultative teams, whether it's inpatient or outpatient. So 90 to 95% of National Cancer Institute recognized centers have that, but there's only 71 centers in the nation that are recognized as National Cancer Institute. So just over one per state. Most cancer patients do not receive their care in an NCI designated institute. And in our state, there's only one or two. And I showed you what a rural population we have in Kentucky. So most of our patients are not at NCI designated cancer centers. Most of the patients in our state and in our nation do not yet have access to palliative care. So we're increasing the workforce in other ways. One is through increasing number of nurses. The stat is about 10 years old, but we continue to see the trend in increasing board certified palliative care nurses. Our team is trying to increase the number of palliative care social workers and increase the number of palliative care pharmacists as well. The major barrier facing the expansion of palliative care services in the US is the lack of medical physicians. So for cardiologists and cancer patients, the ratio of oncologists to patients is about 150 to 1, but the ratio of patients that need palliative care support is about 1,200 to 1. So a really big shortage there. So we're really trying to think about how do we ensure that all healthcare providers practice palliative care. So the first step is ensuring that we understand what are the basic skills and competencies required of all healthcare professionals. So many of us don't get training in what palliative care is during our medical school or residency training. So we're trying to move that more upstream so that all oncologists, by the time they're done with their training, can provide for a lot of those unmet needs. Secondary palliative care refers to us, so specialists like me, some of you all that are providing that expert consultation and co-management. And then tertiary palliative care are those centers, again, about 71 in the nation, that are those academic centers with access to specialists to teach and conduct research. So other things that we have to do in the United States in order to make sure that we can improve access is think about the right patients at the right time. If there's a challenge for within 8 weeks of diagnosis for patients to see a palliative care physician, and we know we can't meet that challenge, how do we do that? So we think about what are criteria that we could use to prompt a palliative care consult. So there's different tools we could use. Mount Sinai developed this patient screening tool that helps recognize when patients may be referred for early palliative care consultation. So things like stage 4 disease, stage 3 lung cancer, or pancreatic cancer, we know those patients do worse and have a much shorter length of life. Prior hospitalization within 30 days, excluding routine hospitalizations for routine chemo, hospitalization that lasts longer than 7 days, or uncontrolled symptoms. We see a lot of patients in our clinic for uncontrolled symptoms, especially pain. That's probably our #1 referral reason. And we also have to think about, are there ways for palliative care providers, be that nurses, doctors, social workers, chaplains, to be in the home? Because most patients with serious illness are not in the hospital, but they're living in homes, with a good proportion in nursing homes as well. So that's a great area for care in the future. And we have to train a large workforce. One way we're doing that in medicine in the United States is what's called entrustable professional activities. So all trainees have to be observed and signed off on these EPAs to ensure that they are able to discuss prognosis, goals and values, and recommendations for care at the end of life. So I'm glad that's become part of the standard graduate medical school education in internal medicine. And there are a lot of further areas for research in palliative oncology in the United States. So first, we're becoming more and more aware of health disparities. Not only are patients in rural areas less likely to get access to palliative care, but patients such as our Black patients, our immigrant patients, things like that are less likely to have access to palliative care. We see a lot of patients in the United States with concurrent opioid use disorder, especially in rural areas. So we're trying to understand, how do we treat pain and substance use disorder at the same time? I already talked about the need for identifying the right time, the right place, and the right person, and curriculum development to grow our workforce, and also an increased number of really good clinical trials. We want to be able to show, now that we have sort of shown a need for specialty palliative care, we need to understand what's in that syringe. Why are people living longer in palliative care? What are we doing to help improve quality of life? And to really drill that down so we can give really good, effective care for our patients that are the most vulnerable during their cancer treatment. All right. Thank you all so much. This is my email address. If anyone wants to reach out, I'm more than happy to chat with anybody, and glad to chat. I think there'll be time for talking at the end of our 2 presentations as well, or anything in the chat. So thank you all so much.
Thank you so much, Dr. McFarlin. That was a great insight into, what are the challenges which you face in the United States, as well as some of the mechanisms which are in place. I would request anyone to please feel free to, to use the chat box, or even to unmute yourself and have your questions, because I know that Dr. McFarlin is in the middle of a vacation. So I'm really grateful for you that you are still you took it up on yourself to make sure that the presentation goes on. So thank you so much for that. So there is one question in the meanwhile I have for you. It's quite surprising to me that yes, there are a lot of disparities and inequities as far as the global north and global south is concerned. But it was quite surprising in one way to hear that even in the United States, where healthcare is so advanced, that the awareness about palliative care is still on the lower side. Like, how do you deal with that? I mean, what are the systems in place? Like you said, entrusting it to the education systems to make sure it is part of education. But apart from that, how do you deal with that on a day-to-day basis to increase the awareness and to help patients understand that this is not just end-of-life care, there is more to it?
Yeah, I think the day-to-day dealing with it is different than the big idea dealing with it, just like you said. So a lot of it is relationship building. So getting to know the oncologists that we work with, making sure that we're present in the hospital. We try to do a lot of teaching with the trainees, a lot of teaching with the nurses and nurse practitioners, because there's similar studies, like I pointed out, that it's not just doctors, it's nurses. So we try to do that. One of the things that I'm involved in, which I'm really excited about, is actually really early on in diagnosis, giving patients it's actually an app, but you could do it on paper, that asks them to identify what their sort of unmet needs are, and then tells them a little bit about palliative care, and then asks them to check a box if they'd like to speak to their doctor about it or see someone. So we're hoping that putting it in the hands of patients may actually improve access by dispelling the myth there. Now, I don't know if that would apply elsewhere, because I think in the United States, patients have a lot more autonomy over what they can request from their physician than they might elsewhere. But relationship building and dispelling myths with patients, I think, are two ways to do that.
Right. Thank you so much for your inputs. I think that there are currently no questions over here. And I am aware that, being in the situation that you are right now, you may have to leave early. So which we are still grateful for, that you found time to make sure that the session happens. So on behalf of everyone, I would like to thank you, Dr. McFarlin, for taking time out and giving your perspectives about the myths which is there in palliative care. So yes, you will be around for some more time. I'll be glad, and I'll keep an eye on the chat box in the meanwhile. So while we wait for more questions, we'll move on to the Indian perspective on palliative care in the cancer space. Over to you, Dr. Suneesh, for the next part of the presentation.
Can you see my slides?
Yes, sir. Your slides are visible. If you could put it on presentation mode. Yes, sir. Perfect.
Thank you, Palliative India, for this opportunity. And I am here to discuss some Indian perspectives regarding palliative care in cancer. So the basic thing everyone knows is my talk will be like there will be something regarding some introduction to the palliative care and what happens in India when you have a chronic long-standing disease. So what happens, what was the history, what is the current status, what we achieved over last 30 to 40 years in palliative care. We have several stalwarts in palliative care in India, so that who made our path very easy for further newer doctors and generation and physicians. So our journey will be very easy by the lights that showed by our predecessors. So thanks to Palliative India. So this is a statement that every physician should learn. Duty of a healthcare provider is to mitigate suffering and to cure sometimes, to relieve often, and to comfort always. So that's what we are aiming with our all the sophisticated technologies and all the cutting edge medical care. We are intended to comfort the patients. That's what we are giving by all our treatments. So for a comfort care, we cannot omit palliative care, palliative aspects of the care, even if you are in a curative setting treatment. So how it integrates, that's the question. So we'll come to the definition of palliative care. There are so many definitions by so many bodies, but one or two will be, I'm just giving. Palliative care is the active holistic care of individual across all ages with serious health-related suffering due to severe illness, and especially those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. Another definition is palliative care is specialized medical care for people living with a serious illness. And this type of care is focused on providing relief from the symptoms and stresses of the illness. The goal is to improve quality of life for both patient and the family. So what it is actually intending is, it's a set of care plans. Actually, the whole palliative care starts from once a patient is diagnosed to have a chronic disease. That point onwards, the palliative care team should involve in the patient care. That's how the system works. Nowadays, it is an integrative care called both the curative and the palliative cares will be start seeing the patient from the day one itself. That's how the things going on in all the comprehensive cancer. When it comes to the cancer care proper, that's how the comprehensive cancer care goes. So you cannot the aim of the palliative care will be go in hand with the curative approaches also. So what are the advantages we are achieving with the some minimal some minute measures that that by the palliative care giving will be producing so much of changes in the outcome of the patient, and that's what we are seeing nowadays. So the palliative care includes living a life-limiting illness with any prognosis, symptom management, maximizing quality of life, palliative chemotherapy or radiotherapy, palliative surgeries, community support, psychosocial support, and in that when the disease goes on and it is progressing and the disease becomes resistant to your curative and control approaches, then what comes? You have to stop. There is a point comes. You have to stop all the active treatment and you make it as an end of life care and later a terminal care. So this whole set of care includes symptomatic management, end of life care, and terminal care. So this is I'm sorry if you cannot see it properly. Actually, this is how the course of illness. It's a picture depicting the integrated approach called. So in the start of the disease, you are giving more importance to the curative approaches. So once as the time progresses, there will be a resistance to the disease, and the curative approaches importance comes down, and it once at a point it will become zero. So in that time, the palliative care approaches will be the maximum. So after a point of time, there will not be any disease-directed therapies. That is end of life care, and eventually death happens. So it's a diagram by WHO. So it's a care for the showing all the aspects of palliative care. It's a care of patients with life-threatening illness and their families. It can be given in homes, health centers, hospitals, and hospices. It improves the quality of life. It benefits by reducing the unnecessary hospital admissions. It relieves physical, psychosocial, spiritual sufferings, and can be done by many types of health professionals. So the various aspects of palliative care will be dealt in further sessions by so many eminent faculties. So I am just introducing some aspects of the palliative care. So it doesn't mean only the symptomatic management. It includes a holistic approach to the disease. It's not a disease-oriented approach. It's a patient and the caregiver-oriented approach. You are giving importance to the patient and the caregiver. It's not just a symptom management. So you are dealing with so many problems at the same time. His family background, his physical symptoms, his psychosocial problems, his occupational problems. All these things are dealt at the same time. And the problems with for the caregiver also, how they are having, how they are facing day-to-day problems with providing utmost care to the patient, how they are managing with his needs and expectations. All these things are managed with certain importance. So we are dealing not the disease per se, we are dealing the patient and the caregiver. So what is the WHO definition? It says that it's an approach to improve the quality of life of the patient and their families. That's more important when it comes to the palliative care. So facing the problems associated with life-threatening illnesses through prevention and relief of suffering by means of early identification, assessment, and treatment of pain and other distressing problems like physical, psychosocial, and spiritual problems. So one important thing when it comes palliative care, it's always in tag with the cancer. One more thing I just want to tell, what is a hospice care? It's what is the difference between palliative care and a hospice care? Hospice care is comfort care without any curative intent, and palliative care also aims for the comfort, but it may include a curative or may not include a curative intent. In hospice care, main aim is to give only comfort and quality of life, and to avoid futile aggressive care. That means some of the disease which eventually takes the patient's life, but the patient will be given will be continued with all the aggressive life supporting measures, and he may end up his life in the intensive care units. So that scenarios cannot be equated with a quality of death. So that patients may deserve a more death quality. So hospice care includes all these aspects. So this is just in a nutshell what is a palliative care just means. So what is palliative care we discussed, and when it is needed. Actually, it starts from the diagnosis and it is maximal at the time of the death. So who needs it? That we will see a little more, and the other things we will see later. So according to WHO, each year an estimated 56.8 million people, including 25.7 million in the last year of life, are in need of a palliative care. So worldwide, only about 14% of the people who need a palliative care are currently receiving it. The global need for palliative care will continue to grow as the result of the aging of population and the rising burden of non-communicable disease and some communicable disease. So what this means that, so the need for the palliative care goes on increasing. The people who are qualified in giving a proper palliative care goes on increasing, because we are seeing more and more aged persons. We are seeing more and more persons with the chronic debilitating illness are sustaining their life. So we need to give quality of care for that kind of patients. So why cancer and palliative care are more talked in together. So actually I'm a medical oncologist. So I was wondering why everyone, when speaking in terms of palliative care, it eventually the major studies quoted and major patient population who are included will be the cancer patients. Why is like that? Because cancer is the leading cause of death worldwide, according for nearly 10 million deaths in 2020, and 1 in 6, every 6 deaths, it is due to the cancer. And according to statistics, one statistic shows that there is a dramatic improvement in the cure rate of cancer by around 20% when it compares 40 years back. We achieved a good quality of curative cancer results. We have reached around 60%, 60 to 70% of cure rate for almost when the cancers are considered together. So, but the problem is there is 40 to 50% of people who are still doesn't get the cure for a cancer. So they will succumb to disease at some point of time. And you know that the problems of cancer, when it is not in control, it will be related to so many distresses. Like the most common will be the pain due to involvement of soft tissues, bone, nerves, viscera, all those things will be there. And there will be so much of distressing symptoms like dyspnea, fatigue. All these will come together when the disease burden increases. So the amount of good amount of a palliative care will needed to control all these problems together. That's why mostly the patients of palliative care are from cancer background. But there are some other disease who needs a palliative care. So which are they? We will see. There are so many other chronic diseases like heart failure, stroke. All those, one study showed that around 62% of the heart failure patients survive 5 years, and 50% of the stroke patients will survive 5 years. So that means in that 5 years, that patient will need a proper symptomatic care. Otherwise, these patients will end up with poor quality of death. So the WHO says that palliative care is required for a wide range of disease. The majority adults need is chronic diseases like cardiovascular disease. Around 38.5% of cardiovascular disease needs palliative care at any point of time. 34% of cancer patients, chronic respiratory disease 10%, AIDS patient 5%, and diabetes patient 4.6%. So these much of patients are in need of a palliative care worldwide. So the amount of palliative care people needed will be tremendous, and they have to work very hard to give proper palliative care for this much of patients. So we know that we cannot even cope up with the cancer patient itself, but when these patients are added to our population, how much work the palliative physician has to give. So there are other diseases like kidney failure, liver disease, multiple sclerosis, Parkinson's disease, rheumatoid arthritis, and neurological disease, dementia. All these needs palliative supports. So this is a survival chart showing the comparison. So when it comes to the palliative care, it's an interdisciplinary team work, including patient, family, palliative medicine physician, primary care physician, nurse, social worker, pharmacist, spiritual leader, counselor, speech therapist, and occupational therapist, dietitians, and volunteers. So it's a teamwork, and it can be given at home, hospital, and hospice. And palliative care improves health in 3 domains: like relief of physical and emotional suffering, improves patient-physician communication and decision-making, and assurance of coordinated continuity of care. So, in this at this point, I just want to say uh, most of our cancer patients, when we are integrating our approaches like palliative care and curative approaches together, they are given counseling at various point of time regarding the course of the disease, how it goes, what are the symptoms you have to expect at some point of time, what are the possibilities you may live for next 5 years, and what are the possibilities you may die of the disease. All these are discussed at certain points of the time. So when the patients are when we are giving information like this to the patient, they also may think in that way. But you may be knowing that there is a difference between Western style and our style, because the most of the decision will be taken by the patient in the Western scenario, and in Indian scenario, the most of the decisions will be taken by the caregiver and the family, not by the patient, because patient will give the authority to the caregiver. And so we have to include the caregiver in our discussions, and we have to decide what all things, at what point of time we have to stop the treatment, at what point of the time we have to give end of life care. All these things has to be discussed prior, when before the patient becomes sick, because at that point of time they may not get the time to understand, may not get the time to digest all these things. Otherwise, all of the cancer patient, all of the chronic heart failure patients will die in the ICUs itself. That may not be the ideal that all of the patients need. So that's the importance of this educating people about the palliative care and the end of life care and terminal care. So we will come to what are the Indian scenarios, Indian statistics about the palliative care. So the estimated number of patients needs palliative care is around 5.4 million per year. That's a huge number. And in India, with near of 1.5 billion people is suffering from life-limiting disease, it comes to a huge number, less than 1% having access to the palliative care. The quality of death indicates the quality of end of life care, and it is not a great in Indian scenario, the quality of death. So the challenges of palliative care in India is most of our patients will, when it comes to the cancer care, the diagnosis comes very late. Most of our patients, we know there are very less screening programs that are intended to detect very early disease. And compared to the socio-economic status of Indian population, most of the people will not be affording any screening programs out of their pockets. Only government supported programs are accessible for the poor patients. So the poor patients will diagnose the disease mostly in stage 3 or stage 4. So that gives a very challenge for the primary oncologist to treat the patient and cure the disease. That's why we have to mostly our patients will go for a palliative intent of treatment, even if they are treated by the oncology people per se. That's in that scenario we faces a lot of challenge, like control of pain, control of symptoms. All those things will be challenges for every patient. And when in Indian setting, there will be a sizable HIV and AIDS patients, and there will be a lot of diabetes patients, a lot of chronic heart disease patients, and estimated 60% of people dying having a prolonged illness. So the number of patients will be huge, and they will be detected in advanced stage of the disease, and there will not be an adequate pain relief. That is the first challenge that we will face in almost all patients. 60 million people in above 65 years of age in 2010 in our country needs palliative care, and this will rise to around 227 million by 2050, coming to around 20% of the population. So this indicates the how many number of patients are going to increase and what will be the unmet needs for these patients. Sorry. And in India, we are seeing a huge increase in the non-communicable disease like type 2 diabetes and hypertension, dyslipidemia. All those things are adding to the chronic illness. What is the second challenge? Like lack of palliative care facilities. India is not equally distributed except in Kerala. Inadequate pain relief is because non-availability of morphine, fear of side effects, and fear of addiction. So, what is in the scenario is in almost all the states of India, there will be a central institute, and almost all the people will be depending on that for cancer care. But considering in the geography of India, there will be problems in traveling, and the access to the central institutes will be very, very limited. So most of the patients will not get a proper care for cancer and all other chronic debilitating illness. So this is a major challenge. And even if they go to a cancer center, most of the government-sponsored center will be interested in treating the curative patients, curative Indian patients. The palliative Indian patients will not be will not get adequate representation in the because the resources are limited in almost all Indian setups. So the more important will be given to the curative patients. That's why the number of doctors or nurses treating the palliative patients may be a little less. And the attitude towards the opioids also is there is a difficulty in dealing that problem also, because the morphine being the addicted opioid, there will be some problem when you introduce the morphine, the word morphine, the people will think some vague. So this is another problem. Another is the poor quality of death indicator. The Economist Intelligence Unit has given India as the lowest ranking in the quality of death index, and the lack of medical infrastructure. That means inequality of distribution of resources. So coming to the timeline of palliative care development in India, this we will see later in detail. Initially, the hospices were places for travelers in 11th century. From the 17th century, the hospices for dying patients came, and the idea of modern hospices came in 1967 in UK after the foundation of St. Christopher's Hospice in London. And in India, the Mary Saunders is the founder of palliative care in India, and in 1986, Professor D'Souza opened the first hospice care by a name called the Shanti Avedana Ashram. This is the Mary Saunders and the St. Christopher's Hospice Center, and this is Shanti Avedana Sadan in Mumbai, situated in Mumbai. This is Professor D'Souza, who, along with the Mother Teresa, is giving care for their patients. This is the first surgeon who started a palliative care in India. So, concept of palliative care is relatively new in India, and for the last 30 years, it came to its existence. The government of India initiated a national cancer control program in 1975 and was modified in 1984 to make pain relief one of its basic services to be provided. Palliative care was started in India from Shanti Avedana Ashram in Mumbai, and later they expanded other centers in Delhi and Goa. In 1993, Pain and Palliative Care Society was formed in Calicut. So that was attached to the government Medical College Calicut as an initially started as an OPD basis, and later they joined with the some programs started with the WHO, and they started giving home-based care also. In 1994, Indian Association of Palliative Care started. Later, Palliative care started in Gujarat under the Department of Anesthesiology in GCRI, and in 1990s, a number of centers started in India. In 2003, an NGO called Palliative India started under the chairmanship of Professor M.R. Rajagopal with the collaboration of WHO. In 2008, Kerala was the first state to declare a palliative care policy integrating to healthcare. Opioid use. Opioids, you know, the cornerstone of palliative care is the
Dr. Suneesh, if I may interrupt, in the best interest of time, we still have a case presentation, and because this is a refresher course of palliative care, everybody is already, you know, have already been through the opioid use and its importance. So if you could, let's just, like, you know, if you could move a little faster, then probably we can move on to the case presentation as well. Thank you so much.
So this is the world map showing our use of opioid. So India comes here, and it is, you know, it's very negligible. So this means so in 1985, the Narcotic and Psychotropic Substance Act developed in India, which had a negative impact initially. So that means after this act, the drastically down. And in 1998, Government of India instructed a state government to produce their own law, but nothing happened. And the current scenarios are like a study by MC Dermot identified 139 palliative care services in India, serving about 1.2 billion people, which is very inequitable. And distribute morphine. That's the current status of morphine use. And these are the challenges that we face palliative care in India, like reaching out to people, availability of healthcare resources, need for some home-based palliative care systems, difficulty in discussion of end-of-life care, and excessive use of futile measures, and disease-oriented approach rather than a holistic approach, absence of communications of patient goals, and the consent of palliative care. And these are the milestones that we achieved in last 30 years, like Institute of Palliative Medicine, educating doctors like essentials of palliative care. Medical Council of India accepted the palliative care as a subspecialty, and they started the first MD course in TMH and the GCRI. Then NDPS Act that amended in 2014 that came to RMI for morphine use, and national program in palliative care. So these are the current Indian scenarios that come across. This slide, my presentation ends here.
Thank you so much, Dr. Suneesh, for once again reminding everyone that you know, the scope of palliative care, even though it's almost always associated with cancer, but you have shown us that even the first cause, you know, the first need of palliative care is in a non-cancer illness, and only then comes cancer. But we would like to hear you know, some of your experience about how being a medical oncologist and having to some extent integrated palliative care in your practice, what has your experience been as far as palliative care in cancer is concerned? What your challenges have been? If you could share some more specifics about that during your tenure of practice. And I apologize that I didn't stress. I think I missed out on that point to mention that you are a medical oncologist. Even though your initial specialty is internal medicine, but then yes, you are trained and qualified medical oncologist as well. Over to you, sir.
Okay. Actually, the approaches have changed over the last 10 to 20 years. Now everyone understand about what is a curable disease, what is a incurable disease, and people are more aware about the death and its problems, and they are more into the more aware of the quality of what they mean by the quality of life. What do they want? What are their personal goals? What do they have to complete by their end of life? So all these things are coming more and more important once we are talking about the quality of life. So what we do is we are when we have to start the treatment for a cancer, we first the first day itself, most of the centers are meeting, giving a consultation to a palliative care physician. So they have a chat with the patient. They also break the bad news. They will give some education about the symptom care, and they will again hear from us regarding the curative possibilities. And after some interviews and discussions, they will know about the chances of cure and the chances of failure. So most of the people are accepting the facts that they have to go for a really what they meant by the palliative care. They are more also those kind of patients are also like easy for treat also, because they will be more those patients who are having access to opioids, and those who are taking opioids for their symptoms, they will be, the quality of life will be better, and we can easily give the curative approaches. We can continue with some more chemotherapies or radiotherapies or something like that. We can prolong we are giving a treatment to prolong the life, and we are giving treatment to control the symptoms. So what I feel is, if we integrate the curative and palliative care at the same time, the patients are more happy, and they are getting more adequate care in all aspects of their life, because a disease being not only producing physical problems, it should be producing impact on their life, their relations, their occupational things, and all these things are involved by a disease, not only the physical problems. So the palliative care team will take all of this as a holistic approach. So I think more care is given by an integrated team. If we are involving all this, we are taking all these things into consideration, and those kind of patients will be getting a better treatment. That's my opinion.
Yeah, thank you so much, sir. It's a very important point which you have brought out, is that this is the advantage of integration. I mean, there are comments about how insurance is a major barrier, and how in the US the palliative care is covered by insurance. But certainly one big role is for integration of palliative care into the specialties. And now, as you mentioned, many a times as you integrate palliative care, you are using the knowledge of palliative care and the principles of palliative care to further prolong certain curative treatments which will be of benefit for the patient. So this is an important aspect which needs to be understood by people of all specialties, where a lot of principles of palliative care can come in, where they can ensure that the patient is on the right page of understanding. At the same time, the curative treatments which needs to go on for a better quality of life for the patient happens. And what best than a medical oncologist speaking the language of a palliative care physician. So thank you so much for bringing that point out, sir. So I think we have about 20 minutes for the presentation. We'll move on to the case presentation, and then we shall take further questions. Dr. Anjali,
Yes, sir.
over to you.
Yeah.
Yes, please continue.
Good evening to all. I'm Dr. Anjali, working as an administrator in Josgiri Hospital. I'm presenting a case, a patient with 44 years old lady with a cancer of larynx, status post surgery and radiotherapy, but now on stomal recurrence and type 2 DM. The presenting complaints was severe fatigue and vomiting and breathing difficulty since 1 day. She was taken to a local clinic, referred to a multi-specialty hospital, and was treated in ICU. But she had a cardiac arrest there, but revived. And there they diagnosed stomal recurrence, and feeding gastrojejunostomy was changed. After 1 week of care in the ICU, she was referred for the palliative care in our hospital. History: as patient was a music teacher and had hoarseness of voice 3 years back, investigated and found out to be cancer larynx, operated and was on tracheostomy since then. She had waxing and waning of the disease as breathlessness, but she was teaching guitar. She was a vocalist, but she learned guitar and she was teaching guitar in the school regularly. 3 months back, she was having difficulty in swallowing and diagnosed recurrence in stoma. So then the feeding gastrojejunostomy was done and the feeding tube was inserted. She had severe breathlessness and vomiting since 1 day. Then she was taken to a local clinic and she was referred to the multi-specialty clinic. She was very fatigued and she was having she had a cardiac arrest but revived. Since then, she was bedridden. She was not able to get up and walk. So she was referred to here for the further care. On examination, she was lethargic, breathless, restless, and she was on low mood. Her vitals were stable except for BP, which was 90/60 millimeter of mercury. Her saturation was 88% in the room air, on tracheostomy and feeding gasostomy tubes. She was ephemeral, conscious, oriented. Disease was 15/15. She had tachycardia and crepes were present bilaterally and rhonchi was present. Her abdominal soft and non-tender. Her HB was 9 gram percentage when she was here, and her sodium, potassium, and his electrolytes were normal. She had low albumin. Her serum albumin was 3.5. She was given antiemetics, bronchodilators, IV fluids, and albumin infusion was given for 3 days. And she was on oxygen at 2 liters through nasal cannula. The medications she was on was morphine 40 mg 4 times a day, and in between. She was on amitriptyline 20 mg twice daily and nitravit 10 mg at bedtime for sleep. Her psychosocial aspect was patient is unmarried. The caretaker of her was her sister, who is a housewife. She's depressed and often got tantrums in the last 3 months because she was on feeding tube So she was not able to taste the food, and also depressed because she was not able to go to the school and teach the children. Worried of her expenses causing trouble to her sister. And she was not accepting her disease and still believing that she will become all right, and even after informing the severity and stages of disease. And also worried about draining the money of her sister's family. She had taken voluntary retirement recently, and this added her depression. The main concerns was being single and future. The voluntary retirement again is a concern for the further treatment, and loneliness and bedridden stage is a concern. Caretaker is her sister with family, not able to attend husband and her children on time. And the unacceptance of the disease and the tubes worry her: tracheostomy, feeding tube, catheter, and nasal cannula. Summary was 44-year-old single lady with carcinoma larynx, status post surgery and radiotherapy with stomal recurrence, presented with recurrent breathlessness, recently revived a cardiac arrest, and now in complete bed rest and palliative care. The discussions was caretaker's concerns on taking care of the patient and her family, and patient's acceptance of her condition, and the counseling regarding disease progresses, and how to occupy the patient in her distress. Thank you.
Thank you, Dr. Anjali. Very heartbreaking story, actually. A vocalist, musician for living, getting CA larynx and getting a recurrence. I mean, what was done for this person? You know, how did things proceed? If you could tell us a bit more, or if you were able to follow up, were you able to follow up with her, or?
Actually, she came in the last last month, and she was in the last stage actually. She, from the multi-specialty hospital, they had told everything that this is the last, and she may be for 1 or 2 months actually. But now, after going from here since last 3 weeks, now she is accepting her condition, and she is ready to go, ready to die peacefully. Now the tantrums are over actually, and the caretaker sister is happy, and she is taking care like a child. She is happy that she had accepted the state of her condition actually, and no other medicines were given now. She had the recurrent stomal recurrence, and it was cleared little bit, but the stoma is getting more, but the tracheostomy tube is little loose also, so that also is a concern for her now. And she had in between the breathlessness and the secretions coming out. The sister is taking care of her with periodic suctions and like that, and she is on nasal cannula throughout the day.
Right. Dr. Suneesh, if you have some questions or thoughts to share about this case.
So a patient coming with a CA larynx recurrence in the stoma and who is breathless. First, we have to see whether any correctable factors are there for her to alleviate the symptoms. Like, is there any aspiration pneumonias or any pleural effusion or any obstruction in the trachea, any obstructive lesions in the trachea, or any cardiac problems due to previous treatments, and any treatable cardiac failure, anemia, all those things we have to see. And if there is any correctable factors, we can give some measures like some antibiotics may relieve her aspiration pneumonia, a pleural aspiration may relieve her dyspnea for some time, and a palliative RT to the mass may give some relief of some obstruction and
Sir, she's on palliative RT. They said she's unable to go for that.
okay. Then only
She
steroids.
was treated for aspiration pneumonia, and now she is not having any antibiotics as such now.
Okay, okay. So an X-ray was taken, no effusions was there.
No, yes, no effusions.
Okay. Is there
She
any
had-
lesion in the lung mass?
In the X-ray, we were not able to see, but actually the X-ray just it was very small. That is, she had aspiration pneumonia
Okay,
when she was
so,
admitted here, and afterwards she was now refusing to take any X-rays and all. Actually, she was
okay.
very stubborn that
Yeah,
not
understood.
able.
So mostly the breathlessness is due to tracheal obstruction. That's what we are.
Yeah, periodic. They had suction
Secretion.
machine with there. Yeah, she is taking out suctions. Suctioning is given periodically, sometimes 6 times a day.
Okay.
Like that, she was giving, and she's very weak. She was not able to walk or able to get up. Very thin. She had become very thin and not taking food. The main concern was her food. She used to take food very lavishly before. With tasty, and now she's not able to taste the food. So jejunostomy feed is giving, but
okay.
And that was the,
So we have addressed all the correctable factors. So now we are just we have to just alleviate her distress symptoms. So we need to give some opioids to relieve her distress of dyspnea, and some sedatives, steroids, bronchodilators, all has to be given to relieve her symptoms.
yeah, she's on morphine 40 mg 4 times a day, sir. In between, she's getting, in between also they are giving, and nebulizations whenever needed.
Okay.
Through the tracheostomy tube they are giving. Otherwise, only amitriptyline she's getting, and now with this, she's better, very much better in her mood wise. Actually, this last 2 weeks, it was she was very
anti-secretory drugs like glycopyrrolate. Anything?
It was not. No, there is no, sir. It was not given.
Okay. Sometimes it may help to reduce the
the secretions.
And a steroid also can sometimes.
She was on steroids when she was here, and while going home, she was not now.
So, do you know what was the event that led to the cardiac arrest? Is it because of the respiratory complete obstruction due to some aspirate, or is it something else?
Actually, they had. I think there may be some. Sir, actually, the cardiac event happened when they have taken out the tracheostomy tube in the ICU.
Okay.
That time she had that cardiac arrest and she was revived immediately.
Okay. So usually, this kind of patient, when their tracheostomy tube get blocked, and if it is not removed or aspirated at the same time, there are events that have occurred. I also had some experiences like that, and somehow she got revived because it was a correctable factor. That then it will be the most likely thing. It's a respiratory hypoxia that has led to the cardiac event. So there is a chance that can occur later also. So we have to discuss do not resuscitate status with her, because otherwise, for her, a patient who is performance status 4 and almost she's now bedridden, no? Almost.
Yeah, she's bedridden, sir.
So for her, I think do not resuscitate status also has to be discussed with the patient.
have talked to her sister everything, and now she was not ready to go, ready to accept that she is dying. But now, since 2 weeks, she is very calm and peaceful, and she is actually smiling and talking to the others, or writing. She is not able to talk, so she used to write it on the paper and give to the others.
Okay.
So apart from this, like, for the psychosocial elements, what was, what intervention was planned or could be finally done for her?
So whatever it is, she was not ready for any counseling. She doesn't want. So whenever somebody is entering into her room, she used to get away from them, and she used to uh, uh, ask them to go out. So
Right.
the counseling was not properly done actually, but there are people or sisters or nurses who are going regularly. So the likewise, the last 2 weeks she is okay. That is, she is ready to accept them and ready to hear them. Otherwise, she was not able to, not ready, and she doesn't want to see any children in this stage because the students. So.
Right.
And now these 2 weeks she is accepting or seeing students and accepting their concerns and their now but she is very weak, and BP is very low still.
Right.
She's getting the medicines through the nasal tube, no? She's getting
Right.
that. Yeah.
Dr. Suneesh, I'm just asking a doubt which crosses my mind at this point. Is that a recurrence, stomal recurrence, which is occurring? Would she have been a person? I mean, what would be the factors where you would consider that we should not, maybe look at further chemotherapy or radiation therapy? Um, had this patient reached that stage is what I'm thinking right now.
Actually, when a young patient comes with a recurrence for a CL larynx, so things we have thinking the factors that we are taking for a treatment, the time duration between first treatment, completion of first treatment and the recurrence. If it is an early recurrence, that means the disease, the biology of the disease is very aggressive, and it will not, you cannot just cure it with any further treatment. So in that case, we just change our line of treatment to a palliative setting. So what we do is we give some, as her age is not, and as she is not ready to accept her disease, so we have to continue some kind of disease treatment which controls her disease to satisfy her. So what I feel is we should have given any second line of chemotherapy. We usually give single agent taxanes like docetaxel or paclitaxel. Sometimes, if the performance score is very good, we will combine it with another platinum agents, and later on we will change to some oral metronomic therapies, including methotrexate, dextinib. All those things are there. If they are affordable, still we can do the MSI status. We can see the mismatch repair status, and we can plan for some immunotherapy if she is a favorable candidate, both with her financial and performance score. For her, I don't think she is not a candidate for immunotherapy because she is not financially fit, and she's not an ideal candidate for immuno. So what we offer will be a palliative radiation or a second line chemotherapy, anything. And if she's having a tracheal compression and all, we could have suggested a tracheal stenting so that she may relieved of some symptoms for some time. and there are endoscopic approaches that can ablate the lesions. So that all gives some symptomatic improvement for her.
Right.
When she comes with a recurrence per se. And somehow we can achieve a control of disease for next 6 months to 1 year if she is good in a good state. I think she may have succumbed to this cardiac arrest when they came to the hospital. That's why they may have changed their plan. Post cardiac arrest, how we will address that may be the reason.
Right. So there are certain unpredictable things which happened, which would have led to a change in the course of management. This actually, like I'm a person from a public health background, community medicine, and this brings me to think that how important it is for us to ask our patients about whether they are part of some insurance scheme, or have they availed of something, government or private, whichever. So it is something which probably is a takeaway for learning lesson for us, is that we need to ask our patients about insurance, and probably even educate them about the need for it, even if it may be an illness which may not take a drastic turn at some point of time. But then this was something which is hitting hard with this particular case which was presented. Dr. Anjali, did she have an insurance, or did you mention? I think I missed
she
that.
had. She's a teacher, sir. She had that in insurance, but it is very late to get medicine and all. It's very.
Okay,
she didn't. She is on insurance with medicine because she is a teacher.
Okay.
The government insurance. She doesn't have a private insurance. Only this much.
So, but because it was too late in the disease process.
That is why. They were planning for the second radiotherapy, but she was very weak, and she couldn't afford any medicines actually. Even the antibiotics, she is having the ulcers and all, even loose motions and all she was having. So it's very difficult to treat her, and her BP was not coming up, and that is why we have given the albumin. So after albumin, she was little better and taking, but we don't know how.
Right. So you have done your best. I mean, your team would have done the best they could in the situation they had, and probably she had reached an acceptance of, like you mentioned, she had reached an acceptance about how things should be for her in going ahead. Dr. Suneesh, any closing thoughts from your end?
Actually, it was very very pleasant to interact with all you, and the importance of palliative care now it's coming very much in nowadays, because more and more people are aware of about the quality of life. That's what they are more thinking about, rather than a quantity of life they are getting with all the treatments. So we have to balance between these two things. So in that case, we have to integrate our approaches, like a holistic approach that includes all these things, like the patient. We have to. We do not want to compartmentalize the treatment like a disease-oriented approach, rather than a patient and its family-oriented approach. And we have to be respectful to the patient also, what they want in their life, what they want to achieve, what they want to complete, for which all relationships they need to revamp. All those things we have to think, and we have to be truthful to the patient also. You have because some information that we are giving has to change their approach also. Like some patients, once we tell you are going to die in a particular time, they will, like, I have seen some patients getting connection with their enemies and all. They will meet again and they will have some, they will solve their own problems. And those things also we have to take care rather than just treating their illness. So that means we have to become a holistic medicine person for treating cancers. And all,
Right. Right,
Excuse
sir.
me, I have a question.
Sure, ma'am. Go ahead.
Sir, may I know what is the usefulness of IV albumin in such last stages of the disease? Or is there any specific protein powder, a specific content or percentage which we suggest for patients who are on chemotherapy or who are not able to take orally anymore?
is that question to me?
Yes, yes.
Okay. So IV albumin in this case, what she told is it's because of intractable hypotension they have started IV albumin, because even if her initial albumin level was 3.5, they have given albumin to raise, maybe it helped in raising the intravascular volume. But usually in my practice, I give albumin if there is very severe hypoalbuminemia with some intractable edema that produces discomfort to the patient. When they say that there is some patients because of the severe edema due to the compression of the IVC, they feel that there is finally the fluid will ooze out from the lower limbs. So in that case, we give some albumin with some diuretics to relieve those symptoms. Otherwise, we don't use IV albumin. As you said, we give some protein supplements through NG tube, or give. Otherwise, we don't give protein at all. Depends on the point of care you are treating. If that patient is a hematological malignancy patient who is having difficulty in coping with an infection, then I will treat with albumin. If you are treating as a curative intent. But if that patient is a stage 4 ovarian cancer, whom we have treated with so many sessions of chemotherapy, and we stopped all the treatment and we are giving only supportive care, and she came with an ascites, I may not give albumin for her. That depends on the symptom, and what we are going to achieve with the albumin therapy is the main thing we consider. We give egg albumin, like oral egg albumin and protein supplements in order to make a balance with the protein loss they are having in advanced state of the disease. And most of our patients will be okay with that.
Sir, any specific amount of protein, like a percentage which should be there in the supplement powder? Like
No,
some people, it should be around 30%, it should be 40%. So like in your practice, how much do you think, what is the usefulness?
No,
What
actually,
protein should advise?
Actually, the nutritional care for a end of life patient is entirely different from that the nutrition to the normal patient, because there the metabolism is there is a drastic change in the metabolism. The major thing that we need to supplement is the energy part. Energy part, if we are giving it is adequately, then the patient will have a good they may not feel fatigued and all, because all the metabolism will be a nitrogen loss that will be producing a nitrogen loss to the patient. Even if we give supplemented all the amino acids and all those things, there will be a negative nitrogen balance that is occurring in that patient. So those patients we prefer to give excess energy rather than protein. So, but by a rule, we say that around 0.8 to 1 gram of protein per kg per day. That is the usual thing we will advise for every patient. But in an end of life care patient, this may not be achieved. But otherwise, almost other patients, we continue with the same plan.
Okay, sir. Thank you.
Dr. Deepak, you're muted.
Sorry. Thank you so much, sir, for answering the questions. And thank you to all participants for participating in the session. A lot of takeaways from this session as well. And one of the primary things which I can think of is to again treat the patient as a person first, and the importance of integrating palliative care in no matter what specialty it is, especially cancer. Thank you so much, sir. Once again, have a good evening to one and all.
Thank you.